options that one must never forget, and they are a must even in today's world?
Indirect ophthalmoscopy for fundus examination
Yeah.
must and must remain.
Yes.
Even if we have a microscope, a good slit lamp and a 3-mirror and a 90D lens for examination of the eye, nothing can be compared to the indirect ophthalmoscopy. It gives a better resolution, it gives better illumination, it gives a comprehensive look, it allows you to see the periphery better, and finally justice can be done to the management of the disease.
So in this era of corporate world, do you think there is a place for a solo ophthalmologist practice, or the trend has to change towards a group practice? What is your opinion about it?
Dr. Kelkar, these things have over the years, if you see, followed the natural mechanism of changing alternately.
Okay.
Just as small shopkeeper in the corner of the housing society compared to the mall, advertising with big show and things, and at times giving discounts.
Yes.
It is in the same way that the solo practice gives a chance for the nearby patient to be a part of the family.
Yes.
You come to the doctor asks you, how is your so and so, your relation?
Yes.
How is your pet working? What it gives a
Personal touch.
It gives you the importance. Whereas the corporate, there is no concern. And moreover, corporates are formed by the people who are not medical people, who are businessmen themselves. And they are concerned with the profit. So they don't look at the fact that the patient has endophthalmitis. He has just come to show you, and you say that you need an injection into the eye immediately, and you tell him you have to spend 5,000 rupees. He says he cannot afford, and you tell him you go wherever you want to. And he goes to another doctor, where he reaches 5 hours later, the endophthalmitis has increased. This is the unethical part of the practice in endophthalmitis, which I'm going to talk in your
Conference.
That you have to give the injection there and then.
Yes.
Irrespective whether you flip is. It's an emergency.
Sure. So talking about the modern technology again, there are market-driven forces which are forcing the young ophthalmologists to take up a path which is probably unethical. So how do you ensure, or what is your message to the upcoming ophthalmologists to ensure that they don't fall prey to the market-driven forces?
Repeatedly, I've been talking, in fact, everywhere I am invited, even to Solapur, where I'm going today evening. They didn't want me to talk on the medical ethics, declining, but I said I'll come only if you allow me to talk. And so I have insisted that the market-driven forces are compelling us to change our attitude towards the patient, and a patient is nobody else but your own extension. And he has to be treated on the same line as you would treat yourself. And in order to meet the challenge, you have to have two things. One is no doubt compassion, and the other is competence. Even not doing the appropriate modern management is unethical. I must practice today's thing. If you don't keep abreast with what is happening today, or what is new instrument which is helping, even then you are unethical in this. So where to compromise? On one hand, we must learn new techniques. On one hand, we must have new equipments which are coming in. And any gain with them allows with us. On the other side, he cannot afford patient of ours. And having spent 2 crore rupees for an excimer laser or 50 lakh rupees for an OCT, how can I remain without earning? After all, I am also part of the same whole as my patient is. So if I serve myself, I am serving him. If I serve him, I serve myself. I have to compensate for the money which I have invested. And we don't deny that. So where should we meet with the compassion on one hand and competence on the other hand? Is by investing less. And that's possible by group practices. We have to join hands and reduce the investment so that it is possible to practice ethically without losing money.
So with the declining patient-doctor relationship, do you see there is going to be a surge of medico-legal cases slapped against the doctors, and how are we going to face this?
It's already happening.
And how should we face this situation now?
Best way is to have group practices where you can put the competence plus compassion together. You will invest less, you will charge less. Same machine. I mean, today there are 21 young lasers in Nagpal. Whereas one can do the job of all the 21. One laser at my place is doing 1 or 2 capsulotomy a day. Whereas it can work 24 hours. For the whole of Ahmedabad, we can do. But it's difficult to convince because we work with the ego of oneself. Somewhere we will have to finally, it's a natural consequence. There is no escape from it. Because the technology is changing fast, and you will have to keep abreast with it.
So talking about the retina surgeons now, there is a shift of retina surgeons doing primary vitrectomy from previously they used to do buckles for surgeries which were primary rhegmatogenous detachments. Is this shift good or bad, or it's because of the market forces that we are landing up in this situation?
No, the shift is good. My only question is that let's keep indications for vitrectomy. Whereas the other group is saying let's keep indication for buckling. As a rule, when you ask management of detachment, he says vitrectomy and I say buckle as the first thing. And then we say if it doesn't work, we go for vitrectomy. He says if it doesn't work, we combine it or we go for buckling also along.
So in the Indian scenario, where does the drug like Avastin stand? Especially when the cost is a major factor, when the patient wants to decide his own treatment.
Dr. Kelkar, even in that I feel a lot of unethical practices are being. We are indicating the injection wrongly at times. We are indicating the number of injections also too many times. We are depending upon the reports of the industry provided to us, which again can be questioned easily. all said and done, even if we consider well-indicated situation for Avastin, we have an avenue that one injection divided into 50 patients can make the thing cheaper.
Yeah.
But we are not making it cheaper. We are not thinking on that line. We are charging the same because we can afford.
Yeah.
But there is another person who cannot afford. We do reduce, but we still. Now, question is, am I justified to charge somebody or something for something just like that? Or I have a reason that I have invested this, that, a reason to account for. So, let's for a moment think again. When you inject Lucentis, you charge for the injection 15,000 rupees. And when you use Avastin, you give the same injection, same syringe,
same procedure.
You charge 2,000 rupees.
Yeah.
Here's the difference. But you are saying that since he's a rich man, I must charge him. These are the clashes of thinking which compel me to mention that, we ourselves, all of us, should have an introspection. How would you feel that somebody cheats you?
Yeah. So talking about diabetic population in India, we are ever increasing diabetic population in India, and we are likely to see a lot of diabetic retinopathy patients, almost like an epidemic. Are we really geared up to face the situation now?
No, we are not geared up. We need to gear up. Even if all ophthalmologists, we are nearly 14,000 of them, start doing some work on retina, even then we may not be able to meet the demand. We have problems at two stages.
Yeah.
One is detection, screening, and the other is capability to do the laser. I'm not talking of vitrectomy, because that has to be at the... But we will all have to do medical ophthalmology because diabetes is... You can see the extent of diabetes, that everybody of us knows two persons who are diabetics. It's going to be that common. And we will have... The problem is very different. We will have to manage it also unconventionally. I have at least thoughts that we should even address this problem to the restaurant owners, to the vendors of the tea on the roadside.